Good morning, everyone. This is Rana. Today we're going to be talking about post-mitral-TEER, echo assessment, and complications. So just starting with the indications in general for mitral TEER, this is where the ACC 2020 valve guidelines. So patients with severe symptomatic primary mitral regurgitation with high surgical risk with morphology that is suitable to have MTEER have a class 2A indication for transcatheter edge repair. In addition, patients with severe secondary mitral regurgitation who fit the co-opt criteria who remain symptomatic by optimization of goal-directed medical therapy also have a class 2A indication as well for MTEER. When we look at the recently published European guidelines for patients with high surgical risk with primary mitral regurgitation, we still have the same class 2A indication for MTEER. But for secondary mitral regurgitation, in contrast to the ACC guideline, the ESC guidelines divided the pathology into ventricular functional mitral regurgitation and atrial functional mitral regurgitation. So now mitral TEER has a class 1 indication for patients with ventricular functional MR who remain symptomatic despite optimal medical therapy. On the other hand, MTEER is a class 2B indication for patients with atrial functional mitral regurgitation. Both guidelines emphasize the importance of anatomical suitability for MTEER, and this here is the traffic light approach going from green to yellow to red. So optimal candidates for MTEER are here on the left. So these patients typically have central pathology with no calcification. Their mitral valve area is greater than 4 centimeters squared, posterior leaflet length of more than 10 millimeters, and a reasonable flail gap and flail width. And on the other extreme end, there are patients where MTEER can be hard or impossible. And this includes patients with mitral valve area of less than 3, and the presence of concentric mitral annular calcification with mitral stenosis, a mean transmitral gradient of more than 5, as well as a short posterior mitral leaflet, and the presence of any calcium in the grasping zone. Just to clarify the terminology, so flail gap and flail width are both important parameters when assessing candidacy for MTEER because they directly determine whether adequate leaflet grasping is feasible. So flail gap is defined as the greatest distance between the ventricular side of the flail segment to the atrial side of the opposing leaflet edge. And this distance is measured perpendicular to the plane of the annulus, and it's measured during systole. On the other hand, flail width is defined as the actual width of the flail leaflet segment measured along the line of coaptation in either the transgastric short axis or bicameral view, and it's also measured during systole. Next, we're going to be talking about echo assessment post-MTEER, and we will highlight some of the complications. So in general, you want to determine whether the device is stable and well-positioned. You should assess the degree of residual mitral regurgitation. We should always assess the transmitral gradients to see if there is any post-procedural mitral stenosis. We should also determine if there is any residual leaflet prolapse, and it's important to look at the intraatrial septum to see if there is any significant intraatrial shunting. And we finally should assess for post-procedural pericardial effusion. There was a guideline that was published in 2019 by the American Society of Echo, which gives us an overview on what to look for during the assessment of residual mitral regurgitation post-MTEER. And essentially, the guidelines emphasize the importance of having a multi-parametric integrated approach, especially that assessment of severity of residual mitral regurgitation can be complicated in these cases. So, for instance, the presence of multiple jets can lead to overestimated of MR severity. And it's important to also remember that EROA calculation by PISA is not recommended in cases of mitral TEER as it's not validated for double orifice mitral valve. So again, you want to look at as many echocardiographic features as possible determine the severity of residual mitral regurgitation. So you want to look at the device morphology. Is it well positioned or not, and whether it has normal movement. If the left atrial volume is smaller in size from baseline versus an enlarged left atrium, you could also consider looking at other qualitative parameters, such as the size of flow conversions, and as well as the pulmonary vein flow patterns. And again, in terms of quantitative measures, ARA calculation by PISA is not recommended after transcatheter edge-to-edge repair. Different mechanisms may lead to recurrence of mitral regurgitation after transcatheter edge-to-edge repair, and it's estimated that about 10 to 18% of patients who received MTEER experienced recurrent mitral regurgitation. For instance, progression of the underlying disease that originally gave rise to the mitral regurgitation may lead to recurrent MR despite having an initially successful procedure. And there are also certain complications that can happen due to disruption of device leaflet interaction. And this includes single leaflet device attachment, loss of leaflet insertion, in extreme cases, device embolization, as well as leaflet tear or perforation, which can happen during the procedure itself. This here is a nice case that was just published in JACC 2 months ago, and essentially they present a case of an 84-year-old man with a history of primary mitral regurgitation and a prior transcatheter edge-to-edge repair. He had severe MR due to posterior leaflet prolapse and had 2 clips implanted at the A2, P2 position, and essentially he presented with progressive dyspnea and was noted to have a holosystolic murmur on clinical exam. Transesophageal echo shows severe recurrent mitral regurgitation with the dominant jet originating between the previously placed mitral clips, and the suspected mechanism of recurrent mitral regurgitation in this case was thought to be related to progression of leaflet prolapse. So in this case, given the patient's advanced age and high surgical risk, the heart team opted for a percutaneous re-intervention. And what they did was a strategy incorporating an implantar device to treat the interclip mitral regurgitation. So this here shows successful deployment of the implantar plug between the previously placed mitral clips, and post-procedural TEE shows an improvement in the MR severity with residual moderate mitral regurgitation. And here on the far right is the transthoracic echo that was done 1 year after the procedure, which shows only mild residual mitral regurgitation. Next, we're going to be talking about single leaflet device attachment, and it's considered to be one of the most frequently diagnosed device-related events with an incidence of about 4%. SLDA is defined as the complete loss of connection between the clip and one of the mitral leaflets. And SLDA can be acute or subacute, and it usually affects the posterior leaflet due to its shorter length. SLDA could be related to multiple factors, such as inadequate leaflet grasping at the time of implantation, or it could be potentially related to the grasping of fragile calcified leaflet tissue. And it could also be related to high tension placed on the clip itself due to anatomical factors, such as having wide flail gaps. So this here is an example of severe recurrent mitral regurgitation post-mitral clip. And what we can appreciate is a detached anterior mitral leaflet from the mitral clip device and leading to severe mitral regurgitation. Our second case here is a 76-year-old man with a history of mitral valve prolapse with severe MR, and he had a previous mitral clip in 2018 where he had 2 mitral clip devices at the A2, P2 levels. And essentially he presented with worsening shortness of breath over the past year and was found to have recurrent severe MR post-clip. His TEE here shows severe prolapse of the posterior leaflet and loss of leaflet insertion, resulting in eccentric and anteriorly directed mitral regurgitation. This patient went for a redo procedure, and essentially he had another clip implanted laterally to the previously implanted clip, and he had another clip implanted just between the 2 old clips as well. And at the end of the case, he only had mild residual mitral regurgitation, and the transmitral mean gradient remained stable after the procedure. So loss of leaflet insertion is a term used when the clip remains attached to both leaflets, but there is a partial detachment of leaflet tissue from the device. And this is different from SLDA, where there's complete detachment of one leaflet. So here on the right is an example of the correct insertion of both the anterior and posterior mitral leaflets into the mitral clip. However, here is an example of loss of leaflet insertion caused by partial tear of the anterior mitral leaflet along the edge of the mitral clip. So the anterior leaflet doesn't insert fully into the device. And on the other hand, here at the bottom, there's complete clip detachment, complete disconnection of the anterior mitral leaflet from the mitral clip. Next, we're going to discuss device embolization, which is a very rare complication with an incidence of less than 1%. This here is an example of a case that was published in JACC last year, and the chest X-ray was done 2 weeks post-mitral clip placement, and 2 out of the 3 clips are seen here in the mitral position, and the red arrow here points to an embolized device. The TEE in this case shows a device embolization with the clip visualized in the sinus of Valsalva. So the risk factors for mitral clip embolization are not completely understood, but may include factors such as complex mitral valve anatomy or the presence of technical challenges and the use of more than 2 clips, suggesting greater anatomical complexity. Our next case here is a 71-year-old female with severe mitral regurgitation. Her TEE shows myxomatous mitral valve with rupture chordae and flail of the A3 segments extending into the medial aspect of the A2 segment, and there's severe eccentric and posteriorly directed mitral regurgitation. As shown here, she underwent a successful implantation of 2 Pascal clips in the mitral position, with one device placed at A3P3 and another one placed at the A2P2 levels. Her transthoracic echo shown here shows that the 2 Pascal clips are well positioned. However, the transmitral gradients was noted to be elevated and was estimated at 9 millimeter mercury at a heart rate of 61, and there was only mild residual mitral regurgitation. So post-procedural mitral stenosis, as defined as mean transvalvular gradient of greater than 5 millimeter mercury. The risk factors for mitral stenosis include small pre-procedural mitral valve area, specifically less than 4 centimeters squared, severe leaflet calcification, rheumatic valve disease, and having any prior valve surgery in the past. Lastly, I just wanted to highlight iatrogenic ASD as a complication of MTEER. A persistent atrial septal defect is present in 24 to 50% of patients. Risk factors include the use of large bore access, extensive sheath movement, and long procedural times. And indications for closure usually include large intra-atrial defects, bidirectional or right-to-left shunt, or symptomatic left-to-right shunt. So this concludes my talk. So just to summarize, MTEER is an effective intervention for severe MR in carefully selected patients. Recurrent MR could be related to underlying disease progression or disruption of device leaflet interaction. Assessment of residual mitral regurgitation here requires a multiparametric approach, and we highlighted some of the device-related complications, including single leaflet device attachment, loss of leaflet insertion, device embolization, post-procedural mitral stenosis, and persistent ASD.